College of Veterinary Medicine, and I co-direct the Center for One Health Illinois with our dean, Herb Whiteley, over here. This is the first of 4 community health public forums that we are holding this spring. We'll have 4 of them here, either in this room or one of the lecture halls across the way. If we get too many people in here, we'll just move. Probably not tonight, but next time. And then we have 2 up in the Chicago area in April and May, and I don't remember exactly the dates. The next one here is going to be March 7th, and after that...
The dates are on the screen, and the Chicago dates follow the...
April 16th and May 11th here, and then also the 16th and May 11th up in, it's actually going to be at Brookfield Zoo.
17th and the 12th.
17th and the 12th up in Chicago, 16th and 11th here, 21st. If I could read, that would really help. So anyways, forget what I said, just read the PowerPoint. So 16th and 21st here, and then 17th and 22nd in Brookfield Zoo. So if you're up in that area and you miss it here. This is the one session that is going to be really eclectic in the topics. We have a lot of topics that we're covering tonight, so you're going to have to kind of pay attention or you're going to miss something because they're all going to be, a lot of them are going to be only about 3 or 4 minutes long. The way we set these things up is that we have experts, topical experts, talk for about 12-15 minutes each, present their data, their talk, and then we go on to the next one, and then we open up the last hour for question and answers. So you have index cards on the tables. If you need more, let us know, and pencils, and we would like you to write down questions as we go, and then we'll field them all at the end. We've used that format in the past, and it's worked out really well. The bathrooms are, of course, out the door and to the hallway that is diagonal to the southwest, if that helps you, if you're directional. It's down that corridor. There's a men's and women's bathroom and a water fountain there too.
Can everybody hear? Should you move this mic?
Everybody can hear, right?
Yes.
Can we, Chris, you wanted a show of hands on how they heard about this? So, what was your question?
I'm just curious what was effective. How many people saw an ad online in one of the Illini Media, Daily Illini or WPG, PGU, or any of those? One. How many people saw an online ad through the News Gazette?
Online?
How many people saw a print ad in a newspaper?
Okay.
How many people saw something on Facebook? A little bit of everything. Did I miss anything?
Equal email.
The college,
Well,
college-wide.
Med email.
So, radio interviews. There are 3 of them, Saturday and then 2 today.
So WILL?
WDWS.
WDWS. Excellent, thank you.
Good.
A little bit of everything worked there.
All right. I don't think there's any more housekeeping things, are there? Dan is going to start out. Dan Lynn, I'm not really too formal on introductions. This is Dan Lynn. Dan is the executive director of the Illinois chapter of NORML, not the city of, but the National Organization for Reform Marijuana Laws. And he's going to lead off talking about where we stand in Illinois, especially in light of the Washington and Colorado election results this November that legalized medical and recreational, or
just recreational in Washington and Colorado.
Mm-hmm. Okay. And did they already have medical?
They did.
Okay, all right, so they expanded it. And then we'll go right in from Dan's talk to a ways vet from Champaign-Urbana Public Health District. Our public health administrator, Julie Pride, is in the back there. So if you have questions for Julie, either during or after, go ahead. Awais will talk about a bunch of pet peeves of the health department, misconceptions, and things that people just don't seem to get a real good handle on at the health department. And then Yvette Johnson's going to talk about one of my colleagues here, a faculty member at the College of Veterinary Medicine, and one of our resident epidemiologists, TDM, and a PhD in epidemiology. Yvette's talking about cell phones and cancer, and
Monsters.
oh, Monster Energy drinks, that's right. And then I'll finish up. Usually I'm just moderator, but today I had to talk about some other things, so I'll finish up with BPA and plastics and milk. So, Dan, start her off.
Actually, you have one slide about the Center
Standing
for One.
Whatever you prefer.
Stand. Excellent. Well, thanks everyone for showing up and being on time. Normally with the people that I'm dealing with, generally they don't show up, or if they do, they're not on time. It's wonderful to have a welcome room of people who want to learn and who are on time. As it was mentioned, I have been working with the Illinois chapter of the National Organization to Reform Marijuana Laws for about 10 years now. What that means is that I do a lot of direct lobbying in Springfield with the lawmakers, as well as educating the public on the benefits of medical cannabis, the need to change these laws, and just simply where we are with cannabis prohibition in this state and in this country. So I'm more than welcome to field any questions that people have on this specific issue of cannabis policy or the broader war on drugs, both in Illinois as well as throughout the country or the world. I do a radio show in Chicago that deals with an analysis of the drug war as a broader term. But without wasting too much more time, I'm going to talk about tonight some of the safety features of cannabis that might not be known, kind of going on this idea of the public health perception versus the public health reality of cannabis. And then we'll shift into some of the stuff that is going on politically, how the laws are changing and where we are in Illinois. So I'll try and be quick going through these slides and try to make sure we have enough time for the Q&A, because that's what I find to be the most valuable part of these talks. Okay, so this will be me, Dan Lynn. Sounds about right? Okay, so when we're talking about cannabis, it's also known as marijuana. I prefer to call it cannabis. That's the scientific term for it. And if we're going to talk about the safety of it, the first thing, and if there's anything people take from my talk tonight, it is this point right here that there have been 0 documented overdose fatalities with humans with cannabis. That is something that I do not emphasize enough. I'm always telling people this. This is not the case with many standard over-the-counter medications. This is not the case with people that have food allergies. But when you think of an illegal drug, when you think of an illicit substance, generally people think that it is extremely dangerous, that there are people dying from overdose fatalities. But that's just not the case with cannabis. This is a substance that has been documented to have been used for literally thousands of years, dating back to ancient Chinese herbal medicines. And with that type of a test plot of human consumption and the fact that there is not a single documented overdose fatality, in my terms and in my opinion, this makes this substance extremely safe in that specific realm. I will kind of go on later about some of the potential risks of using cannabis, but for right now, let's really try and remember that this is a substance, this is a plant that has 0 documented overdose fatalities. In medical terms, they go by the LD50 rating, which is the lethal dose of 50% of the population at that dosage levels. And with cannabis, they just don't quite know what that LD50 rating is. This information comes from a 1988 DEA administrative law judge Francis Young's finding. I didn't put the citation in here, but that's where you can kind of get these estimated LD50s of 1 to 20,000 or 1 to 40,000. And what those numbers kind of reflect is that if the standard dose is 1, what it might take to have that lethal dose in 50% of the population. And that's where they come up with 20,000 times to 40,000 times the standard dose. And if we're talking about cannabis here, people generally think of it as a substance that is smoked. If we went with a typical consumption of cannabis is 1 joint or 1 cigarette that weighs 1 gram. In order to get to this 20,000 or 40,000 level, that would be equivalent to consuming about 1,500 pounds of cannabis in about a 15-minute time period, which, besides being physically impossible, is pretty financially impossible for a lot of the cannabis consumers in this world. But again, anytime you're going to talk about this substance or about illegal drugs, generally the idea that these are extremely dangerous substances, which is why they are illegal, is because of the fact that people can overdose and die from them. But with cannabis, that is not the case. Again, this is something that you will not find the same with over-the-counter medications, things like aspirin, Tylenol, as well as the more powerful opioid-based painkillers that you're starting to see a lot more addiction problems with and a lot more of a criminal justice crackdown on the doctors who are recklessly prescribing these to anybody who comes in pretty much asking for some type of pain relief. And then the other option, or the other notion that people have about why cannabis is illegal, is that it is a gateway drug, and that if you use cannabis, you're going to be more inclined to use other more dangerous substances like cocaine or like heroin. But they haven't really found that causal linkage. This is from an Institute of Medicine report. Everybody hopefully can read, so I'm not going to just read off of this. But that notion of the gateway theory not only has been disproven, but in practice, how it does work is that when somebody goes to buy cannabis, they're buying it in an illegal market from a drug dealer who is already a criminal, who is then going to probably have other illegal substances that people are going to be presented with the option of purchasing. Similar to if you go into a gas station to get a candy bar, and all of a sudden they have cigarettes and alcohol behind the counter. This is kind of a similar reaction to with illegal drug dealers, where they might have cannabis that you came there to buy, but they're also going to try and get you to buy something else that might be a lot more dangerous and might not be what you actually went to them for. But this will be just one of the few, or this is one of many things that kind of disprove the gateway theory that you hear a lot about in the news or when you're publicly debating this issue. Another thing that I face when I'm debating this issue or talking to politicians is they have these statistics of people who have gone into rehab or have gone to a substance abuse clinic for their cannabis use. And this is a pretty significant number. In 2009, you're talking about 350,000 people. Of course, you know, out of the total number of people for all substances, it only serves about 18%. To me, this is still something valid. It's something that I respect when the opposition does talk to me about this. However, this number is pretty inflated, and I'll show you why in the next slide, because a lot of the people who are checking into rehab for cannabis are doing so to avoid jail time. They get arrested, they go to court, the judge says you can either go to jail or you can go get treatment for your cannabis addiction. And most sane people will go to rehab instead of going to jail. And then when they get to rehab, they have to admit that they're addicted to this substance. So that's why those numbers are inflated, in my opinion. You know, if you say out of those 350,000, about just over half of them have been referred through the criminal justice system. Those aren't what I would consider voluntary admissions for an addiction problem or an abuse of cannabis problem. Now, I touched on the gateway theory. I touched on the medical safety, effectiveness of cannabis compared to other opioid-based painkillers. I'm going to transition now into some of the more cutting-edge research and some of the stuff that I think is greatly underreported in the news, and that is, and this is just one aspect of research on cannabinoids, is the anti-cancer and anti-tumor effect of cannabinoid-based medicines. Cancer obviously is a very serious disease that people are extremely concerned about. A lot of people know what it is. There's a lot of news whenever there's a new anti-cancer drug or the potential for a cure for cancer. The thing with cannabinoids being a potential not only for the treatment of cancer, but for the actual slowing of the growth of the tumors, the federal government has known about this type of anti-cancer properties of cannabis since 1974. And just for a quick background, cannabis is a federally scheduled I substance, which means that it has absolutely no medical value and a high potential for risk. That federal scheduling is through the Controlled Substances Act on the federal level. The DEA holds the key to changing that federal scheduling. Just this week there was a court ruling saying that the scheduling is up to the DEA, and if they're happy with it at Schedule I, they don't have to change it, despite the fact that there was a petition to have it changed, despite the fact that there are 18 states that recognize the medical value of cannabis, as well as the District of Columbia. And there's a handful of patients who actually get medical cannabis from the federal government that's grown in the University of Mississippi test plot from an investigational new drug program that they shut down because they had too many applicants trying to get enrolled in this program when HIV and AIDS was really starting to take the country over in the 80s. But back in 1974, the Medical College of Virginia did the study, and this is the results. You have slow of the growth of lung cancers. As much as 36% You know, when someone is dealing with cancer, I think that they are willing to take that number and potentially use it and run with it because people want to survive. There's more anti-cancer studies here. This is more recent, and let me just say that the anti-cancer properties of cannabis are something that are greatly underreported, but it's not the only thing that cannabis can be helpful for. It's something that I just put in this to really try and get people's interest piqued because I don't want to take up too much time. I want to make sure that people understand that there are other medical uses of cannabis, but it's the anti-cancer ones that I feel are being so underreported that it's necessary for more people to know about it. And if you want more research on cannabinoids, which are the chemical compounds found in the cannabis plant, there's two organizations that are doing a wonderful amount of research. The first is the International Cannabinoid Research Society, and the second one is the International Association for Cannabinoid Medicines. Both of those organizations are very well respected. They are made up of scientists, doctors, and scholastic researchers looking at these chemical compounds found within this plant. And to get more into the political world and where we are today, as it was mentioned, the states of Washington and Colorado have legalized cannabis. They did this in November through their ballot initiative processes. Cannabis was made illegal on the federal level in 1937. Since then, again, there have been 18 states in the District of Columbia that recognize the medical use of it. But now we have 2 states that have ended the entire prohibition and are starting to regulate and tax the adult responsible use of cannabis. In Colorado, that means that they're going to be allowed to possess up to 1 ounce as well as 6 plants. There are mechanisms for how people will be able to acquire this. Most recently, there was a members-only club opened in Colorado where people cannot purchase cannabis there, but they can bring their own and they can consume it on site, and they're completely within the realm of the state law. It is still a federal crime, but the vast majority of drug arrests are made by a state or local law enforcement officer and not by a federal agent. And then Washington State does not have the provision for allowing people to grow their own, but they are still allowed to possess 1 ounce. Here in Illinois, we've been working for about 10 years to pass a working medical cannabis law because there's already a law in the books that allows doctors to engage in research with medical cannabis, but the program has never been implemented because the Illinois State Police never wrote rules for the Department of Human Services to ever implement this program. When it was passed in 1978, it was supposed to be used in conjunction with the federal government's research program that they ended up shutting down. But that's why we have this law on the books that's just not effective, and it does nothing to protect patients who are using cannabis with their doctor's recommendation, any type of legal protections in court, as well as any type of safe and legal access to acquire their medicine. Because right now, even if you are a medical cannabis patient in one of these 18 states like California or Colorado, even if you get arrested in Illinois, you show up to court with your doctor's note from California or Colorado saying, my doctor is recommending me to use cannabis for my condition. In Illinois, we do not recognize that, and you are still subject to the penalties of the law, just like anybody else. And that's a terrible thing because I've known patients who've had to move out of state to get access to this medicine. I've also known patients who have died of leukemia waiting for this medicine to become legal in Illinois. And just seeing the heartbreak of people who are struggling to survive with serious and debilitating conditions, trying to navigate the political process. And in Illinois, it's one of the worst processes in the country. I'm not going to get into a tangent about Illinois politics, but this is what's happening in the rest of the country. If you want to look at the rest of the world, Uruguay's president is looking to legalize cannabis in their country, mostly for a production and manufacturing standpoint. Other states are considering medical cannabis, states like Kansas, states like Iowa, South Dakota. So it's not just this West Coast thing, there are states on the East Coast. Michigan is the only state in the Midwest at this point. But like I said, we're trying to do this in Illinois to help patients. We are also trying to legalize this for all adults. But right now, we are most close to getting something done for medical patients in Illinois. Again, I'd like to just mention that there are no overdose fatalities for cannabis, yet the government is still saying that it has no medical value and it's an extremely dangerous and addictive substance. Again, I'm here because I believe in legalizing cannabis. Don't necessarily believe me and trust me on all this. Go out and do your own research. and question the motives of the people who are talking to you about this, because there's a lot of misinformation about cannabis and about the war on drugs. I was talking to Dr. Herman before we started today about how they literally took cannabis out of the pharmacopoeia for doctors when they made it illegal in 1937. And that's why so many doctors now don't even know about these medical values. But thank you very much. I'm going to try and keep it quick. Hopefully we can get some good questions and comments during the Q&A. So thank you.
So I believe I'm up next. And this was really all part of our strategic plan. We thought after Dan talked to you about marijuana, you might be feeling kind of mellow, so I'm here to talk to you about energy drinks. And I have to admit, this has got to be one of my favorite brand names. There's definitely a controversy surrounding energy drinks and health, and thought I'd talk to you about that a little bit this evening. So people talk about energy drinks as something new, but really they've been around for quite some time. I think the original energy drink was Coca-Cola. When first formulated, it included coca leaves and cola nuts for the cocaine and caffeine in both of those products. And so really this is kind of the original energy drink. Subsequently, they decided that it was probably a good idea to remove the cocaine from Coca-Cola, and then actually in the early 1900s, standards were put in place. They were threatened to stop the production because of the caffeine levels, and so Coca-Cola actually reduced its caffeine levels as a result of the threat of legal intervention. Since then, in the U.S., we've had something called Dr. Enough, which apparently is still available in limited markets since the 1940s. And it's B vitamins, caffeine, and cane sugar. And so really, ingredients very similar to a lot of the energy drinks currently on the market. And kind of the grandfather of the more recent energy drink, Jolt Soda, 1985. And their slogan was all the sugar and twice the caffeine. And so again, combining caffeine and sugar to give people kind of an energy burst. Most recently, originating in Germany, I believe, Red Bull, since has been on the U.S. market since about 1997, and still maintains about 50% of the energy drink market share in the U.S. And there's been a huge market growth in energy drinks, starting in 2001 with about $8 million worth of sales of energy drinks, with a growth now to 2011 of about $7 billion. And it's expected that this growth will continue through 2015, and it's expected that there'll be about 150% increase in growth in the market for energy drinks between now and 2015. So what's in them? Most energy drinks are primarily caffeine as the active ingredient. They tend to have about 3 times as much caffeine as in a typical soda. A lot of other energy drinks also include B vitamins, taurine, and guarana. Many of them include ginseng, ginkgo, creatine, and yerba mate. One of the issues is also that in addition to the caffeine, that guarana and yerba mate are also caffeine sources that may be present within the energy drink. In addition, ginseng is thought to potentiate the effects of caffeine, and so you're really potentially getting a pretty high stimulant boost. A lot of these drinks also have a very high sugar content, although several of them have a diet or sugar-free formulation too. So what are the effects? Studies have documented that there are beneficial effects: increased alertness, enhanced mental and cognitive performance. There have been studies looking at tired drivers where they found that reaction times were enhanced and lane drifting was reduced after consuming an energy drink. Other studies have said they found increased upper body muscle endurance. A lot of publications identified mild to moderate euphoria as an adverse effect. I kind of like a little euphoria. I think that's perhaps beneficial. But then there's always a downside associated with heavy consumption, including insomnia, nervousness, in particular of concern, cardiac arrhythmia, nausea, and sometimes seizures as a result of kind of that crash after the effects of the sugar and the caffeine. And so looking at a comparison of some of the common drinks, you see our Coca-Cola Classic, not the 1888 version, but the more recent version with lower caffeine levels. It's got about 3 milligrams of caffeine per ounce. Mountain Dew, which is known for having a higher caffeine level, again, 4.5, so about 50% more. And McDonald's large coffee, so your standard coffee has got about 9 milligrams per ounce. And your Red Bull energy drink comes in pretty close, just a little higher than your standard coffee, 9.5 milligrams per ounce. And then this goes all the way up, looking at your Monster energy drink, 10 milligrams per ounce. And then here we see my old standby, your Starbucks Grande, at again, a whopping 21 milligrams per ounce. And so really most of the standard energy drinks that people are consuming have caffeine levels comparable to a lot of other beverages that we typically consume. Perhaps more concerning may be your 5-hour energy shots, where again, for a 2-ounce beverage, which is the serving size, you're getting 69 milligrams of caffeine per ounce. And so you can see having just a couple of 5-hour energy shots can put you at some pretty high caffeine levels. And then most disturbing of all is something called 5150 juice energy shots, which actually each ounce has a dose of 500 milligrams of caffeine, which actually puts you at a level of potentially causing caffeine toxicity. So you'd probably be better off drinking arsenic, I think, than a couple of shots of 5150 energy drink. And so there have been a lot of health concerns because of this. First of all, there's been a documented increase in ER, emergency room visits, due to caffeine toxicity of about 10-fold. And this is reflecting about 1,000 cases in 2005, up to 13,000 cases in 2009. And again, this really correlates really well with the rise in use and popularity. So I don't think it's necessarily that a greater percentage of people drinking energy drinks are having problems, but as more and more people are drinking energy drinks, you're going to see more and more people who are having problems and showing up at the ER because of it. Most of the adverse reactions are people who've had 2 to 8 drinks within a 24-hour period. Usually people who've consumed in the equivalent of more than 200 milligrams of caffeine. Most concerning is most of these people, more than half of those showing up at the ER between 12 and 25 years of age. And so, again, this is a fairly young demographic that is consuming a lot of these energy drinks and reporting adverse effects. And often they have other underlying health conditions. And unlike cannabis, which hasn't had any fatalities, there have been 18 deaths associated with consumption of energy drinks. 11 have been associated with the 5-hour energy shots, and 5 with the Monster energy drink. And the one that's been most widely publicized is Anaïs Fortier, whose family is currently suing the manufacturers of Monster drinks. She's a 14-year-old. Reports indicate that she drank a 24-ounce Monster drink one evening. The next afternoon, drank another 24-ounce Monster energy drink, and within a few hours was in cardiac arrest. She remained in a medically induced coma for about 6 days, never recovered, and her autopsy results in reports indicated that cardiac arrhythmia due to caffeine toxicity were the cause of death. And she's typical then of those with adverse reactions. She had 2 energy drinks within a 24-hour period. She consumed more than 200 milligrams of caffeine. She was 14 years old. But she also had underlying health conditions. That she had mitral valve insufficiency, so she had a valve in her heart that was leaky, and so it may have predisposed her to suffering both the arrhythmia and cardiac arrest from the caffeine consumption. In addition to the 18 deaths, FDA has reported several instances of non-fatal and sometimes serious, however, health effects that have been associated with people consuming the energy drinks, 5-hour energy, Monster energy, and Red Bull. So, where are the rules? Where are the regulations? Well, so they could jump on Coca-Cola and get them to reduce their caffeine level because soft drinks are food. So FDA, the Food and Drug Administration, can limit caffeine levels in soft drinks and substances like that. And so there's a limit of 71 milligrams per 12-ounce serving in soft drinks. Energy drinks are considered dietary supplements and not food. And so there's no limit on the caffeine content that they can have. And the producers are not required to list the caffeine content. Some of them have caffeine content listed, others don't. But they're also not required to list all the ingredients. And so other compounds such as Urbana, yerba mate, and ginseng, and things that may either have caffeine in and of themselves or potentiate the effects of caffeine may be in these products, and consumers may be unaware. Then the other question is, well, what happens when you mix alcohol with energy drinks? And so this particular product, Four Loko, kind of had the nickname for a while, Blackout in a Can. And as you'll see, it's 11% alcohol. It says fruit punch flavor with caffeine. And so it's a caffeinated energy drink with alcohol in it. So again, what's in it? Most of them, they began being introduced really around 2002. One of the first products was Sparks. Now there's several other products that had been produced between this period, between 2002 and 2007. Most of them have about 6 to 12% alcohol. Most beer is about 4 to 6% alcohol. And so usually one serving of many of these was the equivalent of drinking 3 or 4 beers. And again, they've got that energy drink mix of caffeine, taurine, and guarana. Some have ginseng in them. And they also have usually a high sugar content. In fact, some of the beverage industry publications describe them as alco pop. And so it's soda pop with alcohol in it, essentially, and caffeine. So what does the research say about the effects? Really, they're conflicting reports. At least 2 studies identified risks associated with consuming these drinks with energy drinks and alcohol mixed in them. In terms of those who were drinking them had a reduced awareness of how intoxicated they were, and they had increased alcohol consumption and increased alcohol-related negative consequences. One of the challenges is kind of your body protects itself from alcohol consumption by passing out when you've had too much to drink. Well, caffeine counteracts that, so you don't pass out. You can keep drinking and drinking and drinking. And so you've got the potential for 2 things to happen. Either alcohol toxicity or caffeine toxicity in those situations. But again, these were a couple of studies that looked at interviewing people kind of after the fact and asking them about their drinking behavior and some of the consequences. And if we know anything about behavior, we know that the more you've had to drink, the less you remember about what the consequences were and what else happened. And so there's some limitations to these studies. Several other studies have reported there's no effect at all. And those studies really were of a very different nature. There were 3 or 4 studies that were set up more like a clinical trial, where they took individuals into a setting. Some got a placebo, where they got essentially soda. Others got the energy drink alcohol mix, and they looked at having them perform various tasks and complete certain tests, and found no significant effect comparing alcohol alone to alcoholic energy drinks. But that's really a very different situation, because you've got individuals who were not setting out to go party. I'm sure they didn't allow people to drink to the point where they were either in danger of alcohol intoxication or caffeine intoxication. So in that very controlled setting, they really didn't find differences. So we're still uncertain about some of these risks that they have identified. However, in 2009, 25 different states' attorneys, including Lisa Madigan of Illinois, began investigating the companies producing the caffeinated alcohol beverages. And they felt that those companies were engaging in inappropriate marketing to teenagers, and that the health effects, including blackouts and massive intoxication, posed a risk. Then in 2010, there were reports of injuries and blackouts at several colleges and universities. A college in Washington State had 8 students who were at a single party who were hospitalized as a result of consuming the caffeinated alcohol drinks. And another college in New Jersey actually had 28 students hospitalized as a result of consuming these all at the same event. So colleges and universities, state and local liquor boards started looking into placing bans on the sale or consumption of these products. Then in November of 2010, the FDA sent a warning to manufacturers, because now we're no longer talking about a dietary supplement, we're talking about something regulated by alcohol, tobacco, and firearms. And so they said that the caffeine added to those alcoholic beverages poses an unsafe food additive. And so that beverages that combine caffeine with alcohol are a public health concern and could not stay on the market in their current form. And so as a result, all of those drinks have now been reformulated without the caffeine. So you may still see those names on the shelves now, but they've removed the caffeine from all of those products. So what's the take-home message? I think energy drinks in general can be relatively safe, safely consumed, if, and that's a big if, you're an adult and you've got no underlying health problems, you're limiting your consumption to 1 serving a day, and that serving has less than 400 milligrams of caffeine, and you're careful not to get dehydrated. And so if you're following those rules, you can probably safely consume some of those energy drinks, except perhaps for that 5150 stuff. At the same time, however, they're potentially deadly. If you're a child or a teenager, if you've got any underlying health problems, whether you're aware of them or not, the cardiac defect that the young lady had before was thought to be of no significance to her health. And so it was thought to be an innocuous situation. However, when mixed with those 2 energy drinks, it proved to be fatal. And again, if you're consuming more than 1 serving in a day, and we need to consider that day 24 hours, perhaps not just you slept in between. And also combining them with physical exertion or dehydration, alcohol or other drugs and medications. In those circumstances, there really is a potential for them to do great harm. So now that I've, now that I've taken away your favorite energy drink, let's take away everything else you love, your cell phone. So, do cell phones cause brain cancer? Or is this yet another urban myth? So the first thing people think is, well, you're exposed to radiation with cell phones, radiation causes cancer, right? So cell phones cause cancer. Well, not quite. The radiation that you're getting from a cell phone is not the same as the type of radiation you're getting from X-rays or the type of radiation you're getting from gamma rays. So it's not the same as the scanner in the airport. It's radio frequency radiation, it's non-ionizing radiation, so it doesn't change the structure of atoms, it doesn't induce any chemical changes, and so it's really much less likely to cause any sort of a health problem. In addition, there's still limits to our safe exposure that have been set by the Federal Communications Committee, FCC, Commission. They've standardized how much exposure you can have, and they've said that phones sold legally in the U.S. are safe because they meet that safe absorbance level rate of less than 1.6 watts per kilogram. And there have been several different studies that have looked at whether or not cell phones are associated with brain cancer, and the results have been conflicting. You've got 3 studies that found an increased risk, 2 of which were case control studies where they looked at individuals after the fact, and either they had a brain tumor or they didn't, and they asked them about their cell phone use. Those studies found that there seemed to be an increased risk, especially after 10 years of use. One study was called a meta-analysis, where they looked at a lot of different data from a lot of different projects and reevaluated, reanalyzed that data, and that one said, yeah, we think there's an increased risk and there may be a problem, especially again after 10 years of use. But during the same time, there have also been 7 other studies that said there's no increase. 2 of them were again those case control studies where they looked after the fact and asked people about their exposures in the past. 3 were studies where they combined data from a lot of different places and a lot of different projects to evaluate what was going on. And 2 where they actually followed individuals from the beginning. They knew that they did not have brain tumors at the start, followed them forward in time and monitored how much cell phone use they had, and essentially waited to see who developed tumors. And those did not find any association. So why are we getting these conflicting results? One of the challenges, one of the problems is we think we probably are seeing an increase in the number of brain tumors that have been diagnosed over the past 30 years. But that may just be because we're better at finding brain tumors than we used to be. That we've got better imaging techniques, more sensitive diagnostic tests that allow us to find things that we just wouldn't have found 30 years ago. The other problem is, again, it takes more than 10 years of exposure in most cases for there to be any measurable increase in risk. And so a lot of studies have said they just haven't gone on long enough, they just haven't monitored people long enough to really see any increase in risk. Or that increase in risk may be very, very small. And so you need a very large study with large numbers of people that you're following before you can even find any kind of risk you can measure. Or perhaps only some of us are at increased risk, or certain types of tumors or certain types of cell phones. And so, again, we're not really seeing any difference. Or alternatively, maybe there just really is no increase in risk. And that's what we're finding. So, you can't have your energy drink unless you're perfectly healthy. But there's really very little evidence to support the claim that cell phone use is associated with increased risk of brain cancer. And so, talk all you want, just not while you're driving.
Thank you.
Hello everyone, this is me from Public Health in Champaign, so I hope everyone's awake now that we've had the drinks. So I was going to talk more about facts and misconceptions. You know, at Public Health, one of the things that we do every day is fight fires. We get a lot of calls about so many different things, and people are asking questions, and most of those questions, we feel like they're, you know, mythbusters. Anything's going on in the community, and they will call us to find out what the facts are. In fact, there are times when even professionals, you know, physicians call us to find out what's going on, if it's a fact or not. And so I thought it would be a good time to talk about some of the things that happened in Champaign, so that, you know, talk about those. And when I talk about facts, one thing I want to point out is that for me, fact is based on scientific evidence. And scientific evidence true as of today. 10 years from now, what I'm saying today may not be a fact because there might have been some other scientific evidence which will prove it to be wrong. You know, 30 years back, it was a fact that HIV is incurable. Today it's not. That's not a fact anymore. So keep that in mind also, so that, you know, when I say a fact, it's based on what scientific evidence we have today for those things. Just a quick, you know, plug-in difference between public health and public medicine. A lot of people in this community and elsewhere also don't see the difference, don't understand the difference between public health and public medicine. So public health, what we do at public health here is population-based preventive medicine. And public medicine is, you know, federally funded programs that offer primary care. Public health's role is not to offer primary care, and that's done by public medicine. So there's a small difference, but a lot of people get mixed up between public medicine and public health. Public health is more community-based. Even if we are serving the individual, it is for the benefit of the community. So when we are addressing a communicable disease for one person, the reason for that is we're not trying to address that person's communicable disease, but we're trying to prevent the spread in the community. So it's always community-based. Some things that came up to my mind when I was going to talk about the next three things. You know, in the last 100 years, there have been a lot of achievements in public health. And these, according to the CDC, are the 10 greatest achievements of public health. And all of these, when they were implemented, there were controversies, there were myths about those, there was resistance. But in the last 100 years, these 10 topics or these 10 interventions have had the greatest impact in public health. It has saved a lot of lives. Some of the work still remains, control of infectious diseases, still a challenge. It goes on, it will go on for a long time, but we have seen a lot of benefit by implementation of all these interventions. Let's talk about rabies. Rabies was interesting to me because a lot of calls come to us at the health department. About 4 to 5 people in this community are prophylaxed every single month for rabies, and it's interesting because 10-15 years back it used to be 10 doses of those immune globulin and vaccine given in your abdomen. It's a lot easier now. It's only it's only four series of 4 shots with an immune globulin. But the cost of getting a rabies prophylaxis, if you do not have insurance, can cost about $20,000. That's a lot of money. Even if you have insurance, the out-of-pocket cost is a lot. So there are a lot of misconceptions about rabies. Some of these are, I want to talk about out here. So it's a viral disease. It's mostly found in wild animals. Raccoons, skunks, bats, and foxes are the most common. And when a person is bit, it travels along the nervous system, goes to the brain, causes inflammation over there, and then basically pretty much 100% of the time the person dies. Sometimes these wild animals can also bite domestic livestock, and then the domesticated animals can also get the rabies. So, fact about rabies. In the US at least, most of the rabies that we see is through a bite from a bat. And a lot of people sometimes don't know about this because the bite of a bat is so small that it is very often missed. So if you sleep in a house and a bat is seen in the house after you wake up in the morning, the recommendation is that if you cannot catch the bat, then you have to get prophylaxed. Because the bite of the bat is so small that it may not be visible sometimes. And so if you got up after sleeping and you found a bat in your room and you had not seen it enter or leave, then the recommendation is to take prophylaxis. It's that serious. There's a myth among some people that dogs are still a cause of rabies in the United States. That is actually not true. I don't think in this community in the last 20 years we have seen even one case of rabies in dogs. In other countries it is still endemic, but not in the US. Another myth is that when you get bit by an animal, the first instinct is that you go to the ER and you want to get prophylaxed. Again, that is not always true. As long as the animal is healthy, and if you can, keep the animal in quarantine, the ruling out here is animal control will come, pick up the animal, keep it with them for about 10 days. If the animal is fine, you don't have to get prophylaxed. In case of bats, so if you found a bat, and if you catch the bat can be tested at the state lab, the results come back within 24 hours, and if it's negative, you don't have to get prophylaxed. But if you cannot find the animal, or if the bat is severely crushed, in this case, it cannot be tested. In those instances, then you will have to get prophylaxis. And I specify prophylaxis because, like I said earlier, it is very, very expensive to get prophylaxis. And we've seen people get bankrupt because of paying medical bills. Some other facts also. Rabies always happens from a scratch or a bite. It's not, if it's through blood or urine or airborne, it is usually not possible to get infected through those animals. Less than 1% of the bat, again, I know that I said if you get exposed to a bat, you have to get prophylaxis, but the fact also is that about only 1% of the bats in this country carry the rabies virus. Another fact, possums, usually if you see a possum hissing or drooling and it bites you, the first instinct will be is that the possum was carrying the rabies, so you should get vaccinated. That's also not true. Possums actually are amazingly resistant to the rabies virus. Okay, stomach flu. This is one thing that we also come across a lot. We hear this term stomach flu a lot, and again, this was interesting because people always confuse gastroenteritis, which they think is stomach flu, with the regular flu. Stomach flu is not the flu, which most of us should know. It is a gastrointestinal illness. It is most likely caused by either bacteria, viruses, or parasites. The flu, which is the seasonal flu or influenza, is the one that causes fever, muscle aches, fatigue, body ache, all those things. And those are only caused by viruses. Symptoms of gastroenteritis are abdominal cramps, diarrhea, vomiting. You may have fever or you may not have fever. That's the reason why people get confused, is when they have diarrhea and if their temperature is even slightly elevated, they think that they have what is called the stomach flu. It's not true, it's actually gastroenteritis.